All right, welcome back everybody to another episode of Pathagonia. So today we're going to talk about congenital GI disorders. The first category is developmental remnants or heterotopic tissue. So first up, we've got Meckel's diverticulum, which is an omphalomesenteric or vitelline duct remnant in the ileum, and it contains all layers of bowel. And we can remember for Meckel's diverticulum the rule of twos. So it affects approximately 2% of the population, about 2 inches in length, about 2 feet from the ileocecal valve, and then 2 types of common heterotopia. So you have gastric and pancreatic. And the most common presentation is 2 years or younger individuals, usually presenting with GI bleeding or a current jelly stool, but it can be at any age. And you can diagnose Meckel's with a Meckel's nuclear medicine scan or a technetium 99M per technetate scintigraphy, which is far easier just to say Meckel's scan. And here you see some small bowel mucosa, and then you also have gastric tissue as well. So that is kind of where you get that 2 different types of tissue as part of that rule of twos mnemonic. So Meckel's diverticulum can cause issues throughout or through different mechanisms. You can get a lead point for intussusception or volvulus. You can have ectopic gastric mucosa acid leading to ulcers or diverticulitis. And rarely you can develop malignancy from Meckel's diverticulum. Of note, you can have an umbilical polyp, which is a rarer vitelline duct remnant with intestinal mucosa and the soft tissue of the umbilicus. All right, next up we've got a tailgut cyst, also known as a retrorectal cystic hamartoma. So these are remnants of the embryonic post-anal gut. It's a cystic lesion in the presacral or rectorectal potential space. Multilocular and well circumscribed. And in the image here you can see some disorganized smooth muscle and then as well as cysts. So a tailgut cyst is lined by any GI tract or transitional epithelium, most commonly squamous. It is disorganized smooth muscle bundles as shown here in the image, and there's no well organized muscles or nerves. Tailgut cyst may cause symptoms from mass effect, and it may undergo malignant transformation, rarely. So on the differential diagnosis of a tailgut cyst is cystic sacrococcygeal teratoma, which should have 2 or more germ layers and commonly occurs in newborns. You also can have rectal and enteric duplication cyst, which is well-formed double muscle layer and nerve plexus like normal gut. And you can also have an epidermoid or dermoid cyst on the differential, which has a squamous lining with no smooth muscle. Moving on, you can get a duplication cyst. So duplication cysts are usually single, and they can be cysts with no communication with lumen or tubular, which communicate with the lumen, often running parallel, a true duplication. So you'll have a well-developed double smooth muscle layer with a nerve plexus, and you want to think normal bowel, but just extra. So you can have an esophageal duplication cyst, which is located within or attached to the esophagus, can be lined by gastric squamous intestinal, pancreatic, or respiratory mucosa, versus a bronchogenic cyst, which has respiratory epithelium, cartilage, seromucinous glands, and you can just call it a foregut cyst if it's unclear whether it's esophageal versus bronchogenic, as they are both embryologically related. So shown below, we have a small intestine duplication cyst, which is located on the mesenteric side of the small bowel, usually enteric mucosa, but may have gastric or pancreatic. And you can also get a colonic duplication cyst, which is the least common, and usually has a colon lining, but can have heterotopia. All right, moving on, we've got inlet patch or heterotopic gastric mucosa. So an inlet patch or heterotopic gastric columnar mucosa in the cervical esophagus is thought to be incomplete replacement by squamous epithelium. It's usually asymptomatic and usually fundic type mucosa with parietal and chief cells. It requires endoscopic correlation and versus Barrett's mucosa may be on a differential if at the gastroesophageal junction with intestinal metaplasia. Of course, you would consider Barrett's. The most common site of heterotopic gastric mucosa is the duodenal bulb, which appears polypoid. And versus on a differential, you'd have peptic duodenitis or foveolar metaplasia, which would lack parietal and chief cells. It would just have surface foveolar epithelium. So of note, you can see heterotopic stomach in pretty much any part of the GI tract, including the colon. So good to be aware of. On a similar note, you can have ectopic pancreas, which is, as it would suggest, pancreatic tissue, ductal and or acinar that has no connection to the pancreas. Most commonly, ectopic pancreas occurs in the stomach, duodenum, jejunum, the submucosal mass, and can be mistaken for a GIST clinically. Ectopic pancreas is usually asymptomatic and incidental finding. Rarely can develop an abscess, pseudocyst, tumor, etc. If it's in the second part of the duodenum, it may represent a minor papilla. All right, our next category are congenital enteropathies. So these present with chronic intractable diarrhea and a failure to thrive, usually within the first days or months of life, based on duodenal biopsies. So you can follow this link here, which gives you a great algorithm with recommended IHC panels to work these up. So a recommended IHC panel for congenital enteropathies is BurEP4, CD10, and chromogranin. So CD10 normally highlights the brush border that we see here. BurEP4 normally highlights the membrane, and chromogranin normally highlights scattered neuroendocrine cells. So in the category of congenital enteropathies, we have microvillous inclusion disease, which is caused by a mutation in the MY05B gene. It's autosomal recessive and leads to dysfunctional myosin motor, causing abnormal vesicle trafficking. So atrophic microvilli with microvillous inclusions in the cytoplasm can be seen, leading to poor absorption and severe diarrhea from birth, often requiring TPN. You can have abnormal vesicle trafficking, also associated with Meckel's diverticulum and renal dysplasia. And then on electron microscopy, you're going to see these microvillous inclusions as shown here. And then in this image, you see small cytoplasmic vacuoles in the cytoplasm of enterocytes with variable villous atrophy and inflammation. So here's another example of that CD10 stain. So for the stains, you have CD10 and PAS, which will show a double band at the brush border with apical inclusion staining. So normal is it brush border only to be staining is considered normal for CD10. All right, next up we've got tufting enteropathy. So tufting enteropathy is caused by a mutation in EpCAM, or epithelial cell adhesion molecule, which is involved in tight junctions. And you get this villous atrophy with tufts of rounded teardrop-shaped enterocytes that appear to shed into the lumen. And on IHC, you're going to get loss of BurEP4 and MOC31 staining, which recognize EpCAM, or epithelial cell adhesion molecule. And that would make sense if you think you have a little clip or something right here, like an adhesion molecule holding this villus or villi together. If you have a mutation in that, you're going to have a little bit of a loosening or an unbuckling. So if you just think about the pathophysiology, it kind of makes sense to what we're seeing here. Next up, you've got endocrine cell dysgenesis. So this is a neuro G3 mutation, an autosomal recessive condition leading to absence of the enteroendocrine cells. And on IHC, it's going to be negative for chromogranin A and normal to mildly blunted villi. So some other bowel diseases, you can have lipid trafficking disorders. This is caused by mutations which cause impaired lipid trafficking from the lumen through enterocytes to the chylomicrons in the blood, which causes lipids to build up in the enterocytes, which gives this characteristic vacuolization of enterocytes and fat malabsorption or diarrhea. So some examples of lipid trafficking disorders are A-beta-lipoproteinemia, hypo-beta-lipoproteinemia, and chylomicron retention disease. So of note, some enterocyte vacuolization can be seen in infants normally, but particularly after recent feeds, but it should not be too dramatic. Next up, we've got lymphangiectasia. So these are dilated lacteals in the mucosa. If it's primary, it can be congenital lymphatic obstruction or malformation, and can also be secondary to cardiac issues or localized fibrosis. And lymphangiectasia can present with diarrhea, protein-losing enteropathy, hypoalbuminemia, hypogammaglobulinemia, and lymphopenia, which can lead to immunosuppression and infections. So endoscopically, you're going to see white dots or lacteals. All right, last little category, we've got biliary diseases. So first up, we've got a choledochal cyst, and that is a dilation of the biliary tree, which is an anomalous pancreatico-biliary junction leading to reflux of pancreas secretions up the biliary tree, leading to dilation and obstructive jaundice and a mass formation. So you're going to have a cyst wall with fibrous tissue, biliary lining, and inflammation, as shown here in the image, and it's treated with surgery to prevent obstruction and risk of cancer formation. You can also have extrahepatic biliary atresia, which is fibro-inflammatory destruction of the extrahepatic bile ducts, which leads to cholestasis and biliary cirrhosis. So you want to treat this first with the Kasai procedure, or hepatic portoroenterostomy, as a bridge to transplantation often. So extrahepatic biliary atresia is the most common indication for liver transplantation in infants. And on liver biopsies, you'll demonstrate finding consistent with large duct obstructions, such as cholestasis, a bile duct reaction, portal edema, and acute inflammation. And that's it. Just a quick little episode. Thank you all for your support and have a good day.